Hi everybody, I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and you are on a Dr. Y channel. So we'll continue to talk about your examinations questions, and we are on the pulmonology, and today we'll talk about, open the questions. Today's questions are all about chronic obstructive pulmonary disease. So all about COPD. Okay, so if you find a question like this, and I will ask you the questions, you answer like this. So what is chronic obstructive pulmonary disease? So chronic obstructive pulmonary disease, or COPD, up to you how to pronounce. So what is COPD? Chronic obstructive pulmonary disease is an airflow limitation caused by an inflammatory response to inhaled toxins and often cigarette smoke, alpha 1 antitrypsin deficiency, and various occupational exposures are less common causes in non smokers. Symptoms are productive cough and dyspnea that develop over years. Common signs include decreased breath sounds, prolonged expiratory phase, overrespiration, and wheezing. Severe case may be complicated by weight loss, pneumothorax, frequent acute decompensation episodes, right heart failure, and or acute chronic respiratory failure. No, of course, diagnosis is based on history, physical examination, chest X-ray, and pulmonary functional tests. Treatment with bronchodilators, corticosteroids, and, when necessary, oxygen and antibiotics. Now, of course, first of all, is quit smoking. Stop smoking. No lung volume reduction procedures or transplantation are used in advanced disease. No. Survival is in COPD is related to the severity of airflow limitation and the frequency of exacerbations. By the way, if you answer also that chronic obstructive pulmonary disease comprises chronic obstructive bronchitis, clinically defined, chronic obstructive bronchitis, clinically defined, and emphysema is a pathological or radiologically defined. But many patients have features of both. So anyway, this is a smoker's problem in the vast majority of cases. So if you answer in this manner, it's largely sufficient. If it me, it asks the question about COPD. So you find the question, you answer in this manner, it's fantastic. But actually, I find that there are some details question. For me, it's largely sufficient. But for example, not me, on the examinations. I don't know who, and maybe they ask you here the question classification. So, my friends, chronic obstructive pulmonary disease is a chronic condition, a chronic lung disease that causes difficulty in breathing. It's usually caused by long-term exposures to irritants like, first of all, tobacco, of course, tobacco smoke. Then, air pollution or chemical fumes. Chronic obstructive pulmonary disease is classified based on the severity of the symptoms, the frequency of exacerbations, and the results of pulmonary function tests. I suppose that's what they want from you. The most common classification system used to categorize COPD is so-called GOLD. GOLD, Global Initiative for Chronic Obstructive Lung Disease. No classification system, GOLD classification system. The GOLD system divides COPD into 4 stages based on the severity. So these are severity stages of airway flow limitation as measured by FEV. FEV1, forced expiratory volume. What's 1 in 1 second? FEV in 1. FEV1. FEV1 is once again forced expiratory volume in 1 second, which measures the amount of air a person can forcibly exhale in 1 second. Okay? So the GOLD classification system stages from mild to very severe. Mild, stage 1. FEV is equal or greater than 80% of predicted. Who predicts? No idea. Stage 2, moderate COPD, FEV 1 is between 50 and 79. No, border 80. Huh? Severe COPD, 30 to 49 predicted, and very severe, less than 30% predicted or less than 50% predicted with respiratory failure. Other classification systems may include additional factors such as symptoms, exacerbation history, and comorbidities to further characterize the severity and the impact of the disease. However, the GOLD classification system is widely used and provides a standardized method for evaluating and treating COPD, but for pulmonologists. So why they put a classification? No idea. No, anyway, question is a question. You have to answer. Etiology and pathogenesis. No, etiology, pathology, pathophysiology, classic scam. So chronic obstructive pulmonary disease is a progressive lung disease characterized by chronic inflammation and irreversible damage to the airways. Okay? So the chronic limitation results in thickening of the airway walls and increased production of mucus, which obstructs airflow and impairs gas exchange. In emphysema, the walls of the air sacs in the lungs are destroyed, reducing the surface area available for gas exchange and leading to shortness of breath and difficulty breathing. Actually, emphysema is a sclerotic change. So its lung becomes a connective tissue, like a big scar. The chronic inflammation and oxidative stress in COPD, in chronic obstructive pulmonary disease, also cause damage to the lung tissue and impair the body's ability to repair itself. We have to understand that. So, the chronic inflammation and oxidative stress in this condition damage the lung tissue and impair the body's ability to repair itself, because normally it repair itself in a very good manner, but now it's impossible to repair itself. This leads to a progressive loss of lung function and increased susceptibility to respiratory infections and exacerbations, which can further aggravate the disease. Overall, the etiology and pathogenesis of chronic obstructive pulmonary disease are quite complex and involve multiple genetic and environmental factors that contribute to chronic inflammation and tissue damage in the lungs. Effective management of chronic obstructive pulmonary disease requires a comprehensive approach that addresses both the underlying disease process and its associated symptoms and complications. Diagnosis of chronic obstructive pulmonary disease. Diagnosis involves a combination of complaints. Patient's history, physical examination, and diagnosis tests. The diagnostic process typically includes 5 steps. Patient history. So the health care provider will ask you. Doctor will ask about the patient's smoking history, exposure to lung irritants and symptoms such as cough, sputum production, and shortness of breath. Physical examination. The doctor will listen to the patient's lungs with a stethoscope, and we have to look for signs of respiratory distress, such as wheezing, something like this, wheezing, decreased breath sounds, and increased respiratory rate. Okay? Spirometry. Spirometry is a simple breathing test that measures the amount of air a person can inhale and exhale, and how quickly they can do so. It's the most important diagnostic test for chronic obstructive pulmonary disease. Is used to determine the severity of airflow obstruction and to monitor disease progression. Chest X-ray may be ordered to rule out other conditions that can cause similar symptoms such as pneumonia, lung cancer, or heart failure. But actually, no, if you check up history of the patient normally, it's obvious. But anyway, why not? No echocardiography also we can do to understand what's happening with the heart muscle. No imaging tests. Other tests, additional tests may be ordered to evaluate patients' oxygen levels, lung function, and the presence of other comorbidities that can affect COPD, such as sleep apnea or pulmonary hypertension. Actually, heart failure also goes with chronic obstructive failure very often. So heart failure and lungs failure, pulmonary failure, the most dangerous compilation that can be, combination that can be heart and lungs failure. The diagnosis of this condition is based on the presence of chronic respiratory symptoms and evidence of airflow obstruction or spirometries, as well as exclusion of other possible causes of respiratory symptoms. The severity of COPD is classified according to the results of spirometry and the patient symptoms, which helps guide treatment and management strategies. Treatment and prevention. Treatment and prevention, of course. So the treatment and prevention of chronic obstructive pulmonary disease involve a combination of lifestyle changes, medications, and other therapies to manage symptoms, slow disease progression, and improve quality of life. No, some here are smoking approaches to the treatment and prevention. And first, and the principal one, is a smoking cessation. The most important step in preventing and managing chronic obstructive disease is to quit smoking and avoid exposure to lung irritants. This can help slow the progression of the disease and improve symptoms even more. If patient can't stop smoking, so another treatment, medications, is absolutely unnecessary. So you do nothing. Okay, so medications. Bronchodilators, corticosteroids, and other medications may be prescribed to open the airways, may reduce inflammation, and improve lung function. Inhaled medications are often used to minimize side effects and maximize effectiveness, but the principle is a smoking cessation. No, why not pulmonary and oxygen rehabilitation, oxygen therapy? No, what does it mean, pulmonary rehabilitation? This involves in structured exercise, very good, so-called pulmonary gym, lungs gymnastic. So involves a structured exercise and education program that can improve lung function. For example, balloon blowing, improve lung function, reduce shortness of breath, and enhance overall physical and emotional well-being. So it's actually normal lifestyle with physical activities, one of the best. Now, of course, after smoking cessation. And finally, surgery. It's utopia. It's in some cases surgical interventions such as lung volume reduction surgery or lung transplant may be considered if you are Rothschild or Rockefeller for patients with advanced COPD. Prevention of chronic obstructive pulmonary disease involves avoiding risk factors such as principal one, cigarette smoking, exposure to lung irritants, as well as early detection and treatment of respiratory infectious and other respiratory conditions. We have to say that these persons have, for example, the same influenza very, very badly. The past, the influenza with a lot of complications and exacerbations, a lot of problems, side effects of treatment, etc., etc., etc. The duration of treatment is long. Very often we go to antibiotics, etc., etc., etc. So regular checkups with a doctor can help identify early signs of chronic obstructive pulmonary disease and other respiratory conditions which can help ensure prompt and effective treatment. Overall, effective management of chronic obstructive pulmonary disease requires a comprehensive approach that addresses both the underlying disease process and its associated symptoms and complications. A personalized treatment plan developed in consultation, regular checkup with a healthcare provider, means us, can help maximize quality of life and minimize the impact of chronic pulmonary disease on daily activities. I don't think so that we'll ask you about 15 minutes about one question. Huh? So if you open your mouth and answer just in 2, maximum 3 minutes, it will be fantastic. So thanks, my dear friends, for your attention. See you in other lectures. Don't forget to subscribe and follow the channel. Share this. Of course, you have to share. No, you have to share this lecture with your friends and enemies. So don't forget to, when you're listening the lecture, with the paper, with pen and papers, to make the notes. Notes is very important. No, and re-listening this video several times. Unless you got this under your skin. So God bless you, my friends. See you in another lectures. Bye bye.